Well, thank you so much for giving me the opportunity to speak today to this global audience about subepidermal moisture and as an early detection device for pressure injuries. And I think what we've done is moved into a science where we've moved from subjective determination of a really critical situation to objective measures. And I think that's fabulous. So I'd like to start out again. I have some objectives. I want to make sure that we really understand the foundational events that trigger pressure injuries, because that's the foundation for the science that subepidermal moisture is built on. And I also want to point out the disparities that exist in the epidemiologic profile of patients who develop pressure injuries. Again, that's going to emphasize the significance that this device can make to our healthcare outcomes, our patient outcomes, and describe the relationship between tissue capacitance and subepidermal moisture with the risk of pressure injuries. And then finally describe the clinical application of subepidermal moisture measurement. You saw this illustration before, and I think what I would like to point out with this cycle of the precipitating pressure injury is the concept when I've been in pressure injury prevention and skin care since the early 80s, and we were really emphasizing blood vessel occlusion and arterial occlusion. That's what our focus was, preventing arterial occlusion. And what we've discovered is the actual danger is the tissue deformation that occurs. That's the triggering effect, because those tissues, the cells become distorted, they rupture, they develop death, and as we've already heard, they release toxic cellular contents into the extracellular space, causing inflammation. That inflammation then triggers more perfusion to the area to deliver healing elements and chemicals to the skin. That then develops more poration of the capillaries, so that you have more edema formation. And that is where we're going to find the early detection and a biomarker for pressure injuries, that early microedema that develops deep into the subcutaneous tissue. We then proceed on with more interstitial pressure because of that fluid, because of all the blood vessels. We have then ischemia that's developing because of the occlusion and the pressure against the blood vessels. So now we have ischemia developing, and we have, in addition to that, the lymphatics are occluded, so we're not having the drainage away from that damaged site. We have increased cell death, and then the cycle continues all the way around. And for some of us, those diagrams aren't as useful as just a listing out, a bulleting out of the factors that contribute to pressure-induced cell damage. So I spell them out here, and just to help kind of underscore the significance of that cycle. And what we want to do is interrupt that cycle. And we have the tools now to be able to interrupt that cycle. Our standard of care has been around for years. We've probably had our first standards of care for pressure injury prevention in the early 90s, and they've evolved over the years. They've been enhanced and further developed and detailed. And key cornerstones to current standard of care for pressure injury prevention is the use of the risk assessment tools, as we've already described, and the use of visual tactile skin assessments, key components to pressure injury prevention, because we want to identify who's at risk and identify if there's the extent of the condition of the skin as we currently see it. The downside of these devices, of these strategies, are that the risk assessment tools were developed years ago, and they don't account for several risk factors now that we know put our patients at risk, particularly in critical care. And we also know that they have very high, very variable, inter-rater reliability. So if I do a score on somebody and somebody else has a score, we may or may not really align in our determinations. So they're just subjective, but they're good tools, but we have to augment them with our understanding of the other risk factors to consider. So it relies a lot on the clinical caregiver to really do a thorough risk assessment. And the visual skin assessment, again, it's subjective, The reliability of classification is inconsistent because it's really easy to get it confused with MASD and viral ulcers and bullous disease and ITD, all those confounding conditions. So it takes a trained eye. It's also difficult to identify blanching versus non-blanching. Again, we need a trained eye. But in addition to that, once you see the non-blanching erythema, the damage has already occurred. So you're kind of late. You're kind of behind the 8 ball now, and with that visual skin assessment. But even more importantly, it's difficult to identify color changes in people of color. So these are not, I'm not advocating we throw these out at all. I'm saying we use these, and remember they're cornerstones, and we augment them now with our early detection devices. I want to speak just for a moment about dark skin tones and the disparities in pressure injuries. And I broke these down into several categories where there is disparity. First of all, the prevalence and incidence, which we heard Kathleen talk about. It's 1.7 to 2 times more likely to occur in people with dark skin tones than in people with light skin tones. And that's been reported over and over again. The severity of the pressure injuries are also dramatic. There are higher stage injuries are more common in people with dark skin tones than in people with light skin tones. And conversely, there's fewer stage 1 pressure injuries in people with dark skin tones because we missed it, simply. So they have more severe pressure injuries when they're actually identified. And in addition to that, the time to develop a pressure injury, patients with dark skin tones develop a pressure injury in less time than patients with light skin tones. And why might that be? Again, because we're late in really recognizing the condition of the skin and what is going on. These differences, these disparities occur across all healthcare settings. So it's not unique to critical care or the hospital. It happens in all the healthcare settings. And what I wanted to point out with this slide is that how long have we known about these disparities? We've known about them a long time. Look at this. Dr. Bergstrom first described it in 1996, and then this is just in order of the years, a number of times we've observed this going on. And so to me, this is a call to action. We didn't have the technology to really address these disparities for many years. What we did is we tried to identify better ways or more ways to describe what a pressure injury might look like in the people of dark skin. We started saying, okay, let's moisturize their skin. Let's use the back of your hand or instead of the palm to detect temperature changes. Talk to the family member to see if they think there's a difference in the skin color and does this look normal. So we started doing all these things to try to improve our assessment techniques. Again, they're all subjective. And now we're in a situation where we can really tackle this with objective early detection technology. So I love this slide that Dr. Moore put together to describe where we are currently and what we're trying to get at. And so basically what we do at the current state is we're looking at the skin level and we're looking at visible changes in the skin and we're looking for tactile changes. This is our manifestations threshold. So we're seeing what happens at the skin level. But what we'd like to do is move to this window of prevention, this next level. That's where there's already some subepidermal tissue damage. There's a vascular permeability going on that we already described, some interstitial fluid accumulation, the microedema is going on, microscopic edema is occurring. And that's where we want to move to, that early window of prevention. We want to move there before we get to the damage threshold. So, and that's where the toxic metabolites take over. We have lymphatic dysfunction, nutrients are depleted, the inflammatory process increases and is amplified. So our goal is to move from assessment at the skin level to down below the skin level into the window of prevention. This is a report that was done by Dr. Scafidi, a systematic review There's been several early detection devices described in the literature, and so her study was to look at a review of eligible studies to identify which had the best literature to support its use. So she, in 2020, she found 18 eligible studies. She looked at ultrasound, thermography, subepidermal moisture, and the spectroscopy and laser Doppler. And what she found was that the subepidermal moisture measurement provided the most consistent findings in the early detection of pressure injury. And so this is just to say that these other techniques exist, but what subepidermal moisture has when you're looking at these devices is they have more literature, more research at a higher level to demonstrate the impact of this device and its clinical utility. Other devices have a role. They may just not have they may just be working on improving their science to support the utilization and the bedside clinical application of them. So basically, when we're looking at subepidermal moisture, the concepts are that subepidermal moisture has a consistent distribution in healthy tissue. And we already know this because we know with wound healing, all the tissues are bathed in moisture, and where our goal is to provide a moist wound environment. So we know that there's a consistent distribution of moisture in healthy tissue. What we know also is that localized tissue edema, that microscopic edema, results from injury to the cell and tissue, and that this is the earliest sign of cell death in pressure injuries. So, and this is this coordination with pressure injuries, stage 1 pressure injuries, is thanks to the research done by Dr. Barbara Bates-Jensen. We also know that tissues have this capacity that is dependent on water content. So the more water they have, the more conductive properties they actually have. And changes in that measure of capacitance can be correlated with physiologic events like inflammation and microscopic edema. And again, this is thanks to the research done early on by Dr. Barbara Bates-Jensen. So these fluctuations in subepidermal moisture are indicative of tissue damage, and we can now measure that, and now we can act on it. And I also just wanted to point out that ICD-10 code L89 defines a stage 1 pressure injury as a pre-ulcer skin change limited to persistent focal edema. So the concept is already recognized and in our ICD-10 codes of persistent focal edema or that microscopic edema. So what's this scanning technology look like? How does it function? It's a handheld device. That's what's unique about this technology and really salient in terms of how it's used. It's used at the bedside by caregivers. You can train the caregivers to use it. It's non-invasive. There's no radio frequency energy or current that passes through the body between electrodes. And it penetrates for a depth of up to 4 millimeters. And the relationship with pressure injury damage has been demonstrated with several devices, several types of subepidermal moisture monitoring devices across anatomic locations, among multiple patient populations, across all skin tones, and in various healthcare settings. And we've had consistent findings with all those variables. The FDA has approved this device for detection of sacral and heel pressure injuries. And often there's questions about, well, why not use it on the occiput or on the trochanters or on the ITs? And currently it is supported for sacral and heel pressure injuries. And those are as we saw with Kathleen's research presentation, that the predominant number of pressure ulcers occur in the sacrum. So there's good reason to be using it for those sites and why the company would focus on those sites. This is an example of the procedure for obtaining the subepidermal moisture scores or the readings. Again, we're looking at the sacrum and the heels. And in the sacrum, you're going to obtain 6 measures, and you'll do it right over the bone, and then 2 to the left, 2 to the right, and 1 just slightly above the sacrum. And what we're doing is measuring the amount of moisture over the bone and around it. Because remember, we're saying over the bone is where the damage is. So that's where that microscopic edema is. Surrounding the bone should be more normalized. So we're going to look at what the difference is in the moisture content between those sites. And the device actually helps measure what that difference is, that delta score. And through their research, they've been able to determine that the threshold cutoff score is 0.6. So that 0.6 or greater indicates there's an increased risk of a pressure injury at that site, and 0.6 lower than 0.6 means that they are at a lower risk for pressure injury at that site. The technique is fairly simple. You just hold the device over the designated sites for a very short period. They immediately registers a number, you hear a beep, then you move on to the next site. There's 4 measurements done on the heels. It takes a little training to be really clear on where you need to go on the heels, but you also, the way the device, the readings that you get, you can be trained, or you can be taught that certain scores just are not logical, so you would remeasure them. So there's training involved, but it's really pretty straightforward. So the question with subepidermal moisture measurements becomes, what should the use look like? What's the routine use? And this is the recommendation that's coming out of the National Pressure Injury Advisory Panel that they announced at their annual conference in February of this year. That SEM assessment should be conducted routinely in high-risk populations to identify preemptively skin at risk of breakdown. And the explanation is that the SEM technology detects tissue changes up to 10 days before visible damage occurs, allowing for earlier interventions and better patient outcomes. So the recommendation is to equip facilities with SEM devices and provide training for their use as a part of a comprehensive pressure injury prevention strategy. So notice that it says as a part of pressure injury prevention strategy. So it is a partner with your risk assessment tools and with your skin assessment. Then you would also do this routine subepidermal moisture measurement. So the research surrounding subepidermal moisture has focused in different issues. And one of the issues was time to detection. It was really important to determine really how well does this device detect pressure injuries compared to visual skin assessment. So I was lucky enough to participate in this particular study, and where we looked at the gold standard of clinical skin and tissue assessment and subepidermal moisture measurements in the ICU or in patients who were at risk for pressure injuries. And what we found is that the subepidermal changes occurred 4.74 days before visual skin assessment. And so that's really stunning to me, because that gives you opportunity to intervene. But what's more stunning to me is the number of pressure injuries that occurred in this study. This is a study where we're watching the patients every day. There are 2 different people looking at somebody's doing the subepidermal moisture measurement, and different study person is looking at their skin and doing an assessment. And yet, even with that close scrutiny, look at the number of pressure injuries that developed on the sacrum and on the heels. So that tells me not that we're not doing our job. It tells me that we really don't understand how complex pressure injury formation is. And that's why I feel like it's so timely now that we're beginning to develop objective measures and not relying, and that we can use in addition to our subjective measures to determine pressure injuries and intervene early. We've also, another avenue of the research is looking at sensitivity and specificity, because you need to know that you're actually measuring what you're thinking you're measuring. And Gershon and Okonkwo really identified this early on. They looked specifically at patients with confirmed pressure injury or suspected deep tissue injuries, and they compared to them to confirmed healthy tissue unaffected by pressure injuries. And they reported a sensitivity of being able to distinguish between healthy and damaged tissue, and the sensitivity was 82.2%, specificity 51%. And then even more recently, Dr. Bayumi had conducted a descriptive comparative longitudinal study, and again in the ICU patients who were intubated. And what they did is they compared SEM scores to the modified Kubin and Jackson scale, MCJ scale. And they had an independent rater for MCJ and an independent rater for the SEM scale. And they measured patients for 6 to 21 days. And they were able to report the sensitivity for the SEM is 89%, specificity 77.8%, MCJ in comparison, a much lower sensitivity, and even reported the negative predictive value of 84% with SEM versus 53% with MCJ. Now, the risk assessment tools are not meant to be predictive. They're really meant to capture the condition of the patient. But nonetheless, I think these values are really, again, important to arm yourself with when you're going to go to administration or whoever you have to go to encourage them to purchase and buy into this new intervention, new assessment tool.
A really important aspect of this is the clinical implementation of SEM measurement, isn't it?
So the next area that has been researched by about subepidermal moisture is the clinical implementation. So you have this score, but the question becomes, so what? What do you do with that value? Many people believe they're already intervening in a preventive manner. So what will this give me? And what this particular slide demonstrates is that in this accumulation of different patients in different settings, before they implemented subepidermal moisture, they had 52 patients per 1,000 with a hospital-acquired pressure injury. And then after they implemented SEM, that number went down to 5 people per 1,000 with hospital-acquired pressure injuries. So a 90.5% reduction in the number of pressure injuries. And what's interesting to point out is this occurred in acute care, in community care, and also in hospice care. So it gives us evidence that pressure injuries don't have to occur even in hospice patients, that we need to change our mindset. In addition to looking at clinical implications and how do you use it, the so why of clinical implications, it's important to look at how do nurses respond? What's the response of the caregiver when you get a reading? What do they do? And in this particular study, this is a 950-bed hospital, and they had more than 200 pressure injuries in the past 6 years, and they had per year in the past 6 years. And they were looking at what are the interventions people have used in the ICU and in the orthopedic unit. And what I want to point out, in the ICU, looking at just SEM delta scores, no visual skin changes, they had 18% with an elevated SEM. Those who had elevated SEM and visual skin changes was 12%. And so this 18% would have been ignored if we relied just on the visual skin assessment. So we're increasing your catch of people at risk for pressure injuries by utilizing SEM. Now, what did they do when they found that? They act. The caregivers are acting on that information. They increase their turning and mobilization. They're already probably on specialty beds in the ICU, so they didn't change that. And they also elevated the heels or gave attention to the heels. So that's in the ICU. In the orthopedic unit, again, they had 27% of patients who had an elevated SEM, but no visual skin assessment changes, while they had 4% who had concurrent elevated SEM and visual skin changes. So a total of 31% were identified at higher risk. And what did they do for interventions? They motivated to intervene, and they had more turning and mobilization. They looked at their support surfaces and modified those, and they addressed the heels. So that people are acting on this information, and that's a key component of why subepidermal moisture is so successful. This particular study I was really interested in because this is a study done by Chambers and Thompson, and they looked at pre-implementation, again, retrospectively, for 12 weeks, and they looked at post-implementation of the SEM score, 12 weeks, over a 12-week period. And their intervention between pre-implementation and post was to do the daily SEM, and then to act if the visual skin assessment or the SEM was elevated. They had anatomy-specific interventions already identified, but they included consultation. So it wasn't just the staff responding with doing more interventions for that particular site, but they also consulted with wound care. They consulted with the physician, so the physicians were on board and knew what was going on. They had nutrition come in and do their work. So again, elevating the value of pressure injury prevention to make it more recognizable within the healthcare team, with physician groups, with nutrition, so everybody's responding, not just the nurses doing, changing positions or doing interventions for the site, but everybody's responding. And they had their results where the pressure injuries dropped from 8 per 90 to 0 per 50. And their relative risk of hospital-acquired pressure injuries was 1.6 times higher in group 1, so the pre-intervention group. So to me, what came out of this was, again, the pre-implementation, post-implementation shows us there's a difference, but it also describes the intervention as more than, to be more inclusive, multidisciplinary, which I think is really important. So the question then becomes, okay, we have clinical application. How do you do this? When do you do it? How often do you do it? And the frequency of assessment that I recommend, and that I think bears out in the literature, and there's more research being done on some of these frequency of assessment determinations, is that admission and discharge, bare minimum admission and discharge. Any patient coming in, especially if they're coming from long-term care, especially if they're coming from another institution, and a discharge so you can validate that your patient is leaving and not having leaving with a condition that you might have, that you could be charged with having occurred on your watch. In the ICU, daily to twice daily, and pre and post-op, and some people are using the post-op to go, you might have parameters around how long you do the post-op, but some people are doing the post-op for 3 to 4 days because you begin to see that trajectory coming down over that time period. But really, your frequency assessment is going to be guided by your pressure injury rates, the clinicals, the sites that you're in, risk scores, and the workflow of the staff. We implemented subepidermal moisture in our rehabilitation unit, and that was a big part of what we wanted to know, is what did the nurses find would work well for them in rehab, because those patients are up and moving and having to have a tight schedule. And so incorporating the nurses and determining that workflow and the frequency is really significant and helps in the change of asking them to get this kind of work also done. And then the interventions that are based on the SEM Delta score, if it's less than 0.6, they're going to maintain their current prevention interventions. If it's greater than 0.6 or greater, then they're going to implement anatomy-specific interventions. They're going to reassess the interventions they're currently using, because it might be that they're not being as diligent, or they might not be as effective as they thought they were being. And they're going to ensure that interventions are adequately implemented and achieve additional consults. I really believe that holistic approach of involving the healthcare team is really significant. So the focus should be you detect, you treat, and then you prevent. That should be the sequence of events for how we would use the subepidermal moisture. And this recommendation for subepidermal moisture has been identified by the International Pressure Injury Guideline since 2019. Again, they consider using a subepidermal moisture edema measurement device as an adjunct to routine clinical assessment. And then the other recommendation was, when assessing darkly pigmented skin, consider assessment of skin temperature and subepidermal moisture as important adjunct strategies. Again, that word adjunct, it's not replacing risk assessment, it's not replacing skin assessments, it's an adjunct to those. And even further, the AORN, the Association for Perioperative Registered Nurses, and in addition, identifies the use of this technology to help prevent pressure injuries in the operating room. So in drawing this to a conclusion, what I want to summarize for you is why SIM monitoring. And essentially, there's many reasons, but I think these are the nuts and bolts of it. They enables targeted interventions, early interventions, while the damage is still microscopic and reversible, and therefore has the potential to prevent further damage. Number two, SIM technology detects tissue changes up to 10 days before visible damage occurs, allowing for earlier interventions and better patient outcomes. And I would say 3 to 5 days, but this is critical in that it gives you a window of time to intervene. And there is an 80 to 90% reduction in pressure injuries across all healthcare settings that have been reported consistently. This device eliminates the disparity in pressure injuries based on skin tones. A huge factor, huge motivation for why we should be doing something like this. And even more importantly than all of this, it reduces the costs and the patient complications and the adverse patient outcomes. Pressure injuries are significant. They cause increased risk of infection. They cause increased risk of sepsis, pain, death, all kinds of things. They're bad outcomes. And we need to be much more aggressive in trying to prevent these pressure injuries. So the call to action is that we need to recognize that SEM provides objective data to amplify our subjective data. We need to recognize that erythema and hyperpigmentation are late indicators of pressure injury, and that targeted interventions can reverse this tissue damage, and we can eliminate skin color as a risk factor. There's lots of research opportunities in this very exciting technology. We can learn more about other body sites where we could be using it. We could use more research to look at the clinical decisions based on SIM scores, and look at the frequency of measurement based on the clinical setting, whether they're in the ortho or the ICU or the rehab or long-term care. So in conclusion, this is why subepidermal moisture is so critical. This is preventable, unnecessary harm, increases the risk of all these complications. We should not be satisfied when we intervene and our rates decrease from like 200 a year to 100 a year, or from 100 a year to 50 a year. That's still not okay. We still have people getting pressure injuries, hospital acquired, and we need to be able to intervene. And this is a device that we need to really promote and encourage in our systems. We need to be the patient's most vocal advocate for best practice in pressure injury prevention. We need to be pushing for this because it will cost money. There's a cost to it, but the cost to having a pressure injury is much higher. And we need to help our administration recognize that and own it.